So this evening, it is my pleasure to introduce Dr. Kimiyoshi Kobayashi, who will be giving us a talk titled, "What is the Future of Healthcare Quality and Safety?" Dr. Kobayashi is the Chief Quality Officer for UMass Memorial Medical Group and Medical Center, a role which he has had since 2019. He completed medical school at Johns Hopkins and business school at the Harvard Business School prior to residency in internal medicine at the Massachusetts General Hospital. After completing residency, Kimi remained at MGH as a hospitalist and took on increasing administrative responsibilities, including physician champion for EPIC deployment at MGH, as well as director of inpatient medicine for the Department of Medicine. He transitioned from MGH to Johns Hopkins Hospital, where he worked as a hospitalist and associate medical director of the Johns Hopkins Medicine Capacity Command Center prior to joining UMass Memorial. Kimi's interests include handoff safety and intra and inter-hospital transfers, as well as the impact of capacity management on patient outcomes. He is a member of the Quality and Patient Safety Committee for the Society of Hospital Medicine, as well as the member of the Vizient Chief Quality Officers Network Steering Committee. He is a Boston native, and we here at UMass Memorial were very happy that he joined us and pleased right before the COVID surge. I think since he joined us, he's been involved and done an amazing job at shepherding all of the institution through very difficult times. I have the pleasure of working with Kimi on a regular basis, and it was my pleasure and honor to invite him to give this talk. So Kimi will be monitoring the chat box and also answering questions throughout the talk and at the end. At this time, I'd like to give the floor to Kimi. Thank you, Kimi, for joining us tonight.
Thank you so much, Spiro, for that kind introduction. It is my absolute honor to present to you all today this annual oration. You know, I was looking forward to obviously being in the Beechwood, but the circumstances are what they are, and we're doing it virtual, which is all right, and hopefully, you know, the pandemic will be behind us, hopefully in the near future. You know, I was looking at the history of the annual oration, and I couldn't be more impressed and even more humbled to be giving a talk in something that's in its 226th cycle here. So let me just go ahead and get started. And as I go through the talk, I just want to mention to the all the folks who are tuning into the webinar that please type in your questions in the Q&A, and we'll address them at the end of the talk. Just to start off, I have no disclosures. And the objectives today are really that I wanted to discuss potential future areas of innovation in quality and safety, and understand the impact of the COVID-19 pandemic on this future of quality and safety. And hopefully we'll go through some examples throughout the talk today, but really talk also about clinical informatics and how that can really support clinicians. This is a picture of somebody looking into the future in a white coat, which frankly just makes me think of that I'm just jealous that I would like to practice medicine in somewhere where you can just look out while working clinically into the ocean. But anyway, so I think it's good to start this talk off by talking about what is quality and safety. And I was really pleased to see that in the numerous talks throughout the time of the annual oration for the Worcester District Medical Society, that this topic of quality and medicine has been covered periodically and pretty extensively. So here's an answer to one of the orators when they were asked to talk about what is quality. So the word quality comes from the Latin qualis, meaning of which, and signifies an attribute or property of a person or object. Portia used the word in this sense as an attribute of human beings when she spoke of the quality of mercy. Later it came to mean degree of excellences, and we speak of poor or low quality and good or high quality. Finally, simply high quality or excellence came to be a legitimate meaning of the word. Presumably, this is the sense in which it is used, that is, as excellence in the name of the quality fish market. These last two meanings, degree of excellence and excellence, will be what we are talking about tonight when we say quality. And I think that frankly, this definition still is a pretty good one. This was from the 1973 talk. More recently in the 2000s, the Institute of Medicine has come up with these definitions for both quality and patient safety. And I think it's important that those two things are not seen as exactly the same thing, even though we talk about them in the same sentence. So quality, what is quality? The degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And on the flip side, patient safety, what is patient safety? It's more simply the prevention of harm to patients. As somebody who does quality and safety all the time, I really simplify this a little bit to, when I think of quality, it's do more of the right thing. And when we talk about patient safety, it's do less of the wrong thing. And hopefully that's an easier definition for folks to carry around when we talk about quality and safety. So I thought about, what should we talk about today when thinking about the future of quality and safety in healthcare, which is frankly probably like a 8-day talk if you wanted to cover all aspects of it. And so I tried to narrow it a little bit and try to really answer a question that I hope is very relevant to the practice of physicians and for how we think about how this will impact our daily practice. So the question I think we'll try to get at today is, how will we respond to forces driving the healthcare field forward to ensure care that is high quality and safe? And I'll just say right now, I'm not going to probably be able to fully answer this question, and I'm going to certainly do my best to take you through what I think are some of the things that are coming ahead. I liken this exercise to kind of New England weather. This past weekend was a great example where we went from 60 degrees and then it was snowing the next day. So just proves that you really can't prove the future, but certainly we will, try to predict what might be coming down the road. So as a start, I think it's really important that we frame what are the drivers of healthcare and what are some of the things that are going to be propelling our field forward as we look ahead into the future. This is certainly not a comprehensive literature review, but more of my personal views of what are some of the major driving forces. And I may have left out a couple of things, but I think a majority of these things are true when we think about what are drivers in the future of healthcare. Now, an important thing to realize is that really the COVID-19 pandemic has had a profound effect on a lot of these drivers of healthcare. And you can see some of the ones that the virus is closing up to there on this diagram. I think are in particular some of the ones that really have been pushed forward with the COVID-19 pandemic. And so, the people call it a once in a lifetime pandemic, but I think that this was a really important event in our field, and importantly in understanding quality and safety and how that's going to evolve in the future. So I want to just take a couple of these things and talk with you all today about what do I think it's going to look like? What do we know about quality and safety in some of these aspects? And let's start with virtual care. I think it's been very well documented that really virtual care has exploded through the COVID-19 pandemic. So whether you want to look at telephone visits or video visits or other means, really this explosion in telehealth from the pandemic has been explosive and also sustained. And I hope that it remains sustained. And obviously some of the major drivers that we can talk about from a policy perspective, including payment and other things, are certainly important to keeping that sustainment growing. But I think that probably our patients will expect that this is the new wave of the future. And so I think it's important for us to think about, well, what does quality and safety mean in the context of virtual care? Really, I think the short answer is that we don't really know. I'm confident that this will become a more and more studied area. Here's one example of a study that tried to look at some of the things that might be coming down the pike for us in virtual care. And it looked at as the pattern of practice had shifted from in-person, to telehealth, what the impacts of that have been and some of the things that we consider core to what might be going on in a primary care office visit. So as you can see here, they saw lower blood pressure recordings, which makes sense. Generally in telehealth visits, it's a little bit more difficult to do a blood pressure measurement, and decreases in cholesterol levels being assessed and new medications being initiated. These are really important changes that I think we need to really understand what the impact is going to be, particularly if you think about, in addition to the fact that some of our measurement and rating systems are dependent on some of these things being captured. So clearly that's going to have an impact as we think about how this is going to evolve. I think another thing that we have to really carefully think about is what is the effect in virtual care to the doctor-patient relationship. So this was a small study that looked at patient perceptions of satisfaction and looked at the in-person satisfaction versus the telemedicine satisfaction. And so in both domains, in the top domain, it's looking at physicians' perception of physician clinical competence. In the bottom, it's looking at perception of physician interpersonal skills. And that zero line means basically no difference between in-person and telemedicine. And as you can see, most of these bars for most of these physicians cross the zero line, meaning that most of the time there's really no difference in perceived perception of either clinical competence or interpersonal skills. But I think we need to study this a little bit more. I'm not sure that the classic doctor-patient relationship as we've known it really transcends 100% in the virtual world. And, you know, we can recall other studies like what physicians wear in a clinical encounter affects a patient's perception of that clinician. And so extrapolating from studies like that, I can only imagine that virtual care has to have an effect on the doctor-patient relationship, which is obviously critical to how we treat our patients. Other quality and safety considerations when thinking about virtual care is really what's the impact, for example, on the fact that there's less potential teamwork, right? We're not in an office setting, let's say for an ambulatory encounter, and we don't have our front desk staff, our MAs, our RNs working with us. There's less teamwork. It tends to be a little bit more dispersed. And what is the effect of that? You know, we clearly gain flexibility, maybe even better triaging with virtual care. But does it perhaps lead to more visits? And that's a good question that we still need to answer. There was a study that looked at oncology visits and looked at whether there was any difference in staging, timing of staging, or initiation of chemotherapy, or other outcomes like ED visits or admissions, and saw that it was basically equivalent. And I think we need more studies like this to really understand what is the impact of using virtual care. You know, we talked about that we do less blood pressure, and we can't kind of put our hands on the patient. And does that lead to, in fact, maybe over-dependence on imaging or testing because we don't have those modalities, and what is the impact of that? And a critical question, I think, is really health disparities. Obviously, if we're using virtual care and we're doing that at the expense of leaving behind folks who don't have as good of access to that, then that's clearly not ideal. So my prediction slide on this topic is, you know, virtual care is here to stay, I think, and we're going to have in the future care models that clearly blend an in-person component and a virtual component. We're going to have to figure out the balance of that and how those look. And I think we need to answer some of these really key questions if we're going to really understand the quality and safety of virtual care about what does it mean to not be able to lay our hands on patients and do a physical exam, which has been a cornerstone of a lot of how we as physicians have been trained throughout the years and continue to be trained about the importance of diagnostic skills. And is there more delayed diagnosis or misdiagnosis in the virtual realm? And can we design structures for virtual care where we don't worsen disparities? Really, I think when we think about virtual care, risk-based contracts are going to help us, I believe, and because it gives us that flexibility to design our care so that it meets the needs of our patients more so than in a fee-for-service paradigm. But clearly, payment around virtual care is an important question. So that's virtual care. I'm going to transition us a little bit to another topic. I think another key topic is around caring for the caregiver, and the pandemic has highlighted this pretty prominently. So many studies are coming out now showing that clearly provider burnout is worsening. I don't think we really need studies extensively to all know this. You know, us clinicians know that we feel it when we're out there that burnout is worsening. People are getting tired. This pandemic has gone on a very long time. And, you know, we should all remember that even before the COVID-19 pandemic, the topic of wellness and burnout was increasingly gaining attention. And by all accounts, people were concerned that it was getting worse. And now with the pandemic, getting worse even faster, perhaps. And it's not surprising to see why burnout has gotten worse during the pandemic. There's many different factors that are coming at us in the realm of clinical medicine that is leading to worsened burnout. And it's been a very long road for all of us, and the initial support that we all felt from the community and everyone around us, and the sort of the hope and the excitement clearly has worn off after 2 years, and really we're left with more and more of these hardships, and I think that is continuing to stack up. Now, why is burnout important in the realm of quality and safety? And well, it's because there's a relationship between burnout and the safety and quality that of the care that people are going to deliver. So this is a little bit of a complicated figure here, but it's a meta-analysis looking at components of burnout and studies that have looked at the correlation with quality and safety. So on the left-hand set of slides, the shades of gray illustrate the volume or the number of studies that have looked at that relationship. And then the red and blue dichotomy on the right shows the degree to which those are correlated. So, you know, for instance, elements of burnout are correlated with poor communication and whatnot. And basically, as is probably not surprising, our literature shows that people who show signs of burnout and low wellness deliver suboptimal care and by many different markers of quality of care. And so this is clearly an important issue when we think about quality and safety. You know, the Massachusetts Hospital Association, MHA, has come out with a great task force paper around caring for the caregiver. I've put the link here. And really the way that they have structured this is to think about it in 4 separate big buckets. One is around safety in the workplace and violence prevention. Second is engagement. Third being well-being. And then fourth is thinking about development and deployment of the workforce. And as you can see here, really it's encouraging a very systematic approach to how we approach caring for the caregiver. And I just want to highlight that this work had been kicked off and going on even prior to the pandemic. So kudos to the MHA for that. And obviously it just has gained more value as we've gone on in the pandemic of why we need to do this. And as you can see here, you know, some of the themes are that we clearly need to make transparent the issue of caregiver safety. We need to provide training for our caregivers. We need to make sure that there's leadership engagement and support, and that it's seen as a priority amongst institutions. And we need to develop programs that support wellness and things like peer support programs, so that clinicians have a place to go to confide in each other and gain support. and also make sure that folks are getting a sense of value within the workplace, and that really seems to be a counter for burnout. So that's why that's important. I think a question you might have after thinking about this is, well, what can I do? What can I do as an individual physician? And this was a study that was written by Carrie Palmara, who's at Mass General, has done a lot of work around physician coaching and support. And you might think that, you know, what we should be asking folks is, how are you and how can I help? And that's really not the case. The things that seem to drive a sense of support and well-being is to really drive at this concept of value and making sure clinicians feel the sense of value. And although the title of this paper says, you know, what questions leaders can ask, I would really posit to all of you that us as physicians have a key role to play as physicians, because to a certain extent we assume a leadership position, frankly, in a lot of clinical encounters. So I think that these lessons are important to all of us, and that we can practice this in our everyday life. So what they were encouraging was to ask some of these questions. What are the ways your life has been impacted by the COVID-19 pandemic? What does value and appreciation at work feel like for you? What prevents you from doing a job that you are proud of? And what can be done to move forward and help you do a job you are proud of? And really the point that they were getting at was, when you ask people, how are you doing? Or, you know, these open-ended questions, it can almost be overwhelming to think about the answer to those questions, and that really driving at more specificity of how we support each other in asking and inquiry and offering support can really be helpful. So looking ahead on this topic, I think it's been proven that healthcare heroes need help too, and that burned out caregivers won't deliver high quality and safe care. And I think we need to treat caring for the caregiver not as a side topic that we also have to do, but it's really integrated into the quality and safety imperative of what we need to do to deliver high quality and safe care. I think that clearly leadership commitment and big systems of support are important, and structural issues are important, but I really would not underestimate the power that you have as individual clinicians acting within a clinical encounter, interacting with your colleagues and being able to support your colleagues. I think that's really important, and I think the organizations and practices that are able to successfully deal with this are going to recover faster out of this COVID pandemic and do better in the long run. So before I go to the next topic, I'm just going to continue to encourage folks to type in your questions into the Q&A box, and we'll get to them at the end and go through. So please go ahead and type them in there. Another topic that I wanted to talk about in relationship to the future of quality and safety and the pandemic is the matter of health equity. So I think it's been very clear that throughout the pandemic, it has really highlighted health disparities. And this is data from Massachusetts, as you can see here, which shows the disproportionate effect of the pandemic in terms of cases and hospitalizations, and just, you know, the Latinx and Black community have been affected by the pandemic disproportionately to their representation in the population. And this isn't obviously unique to the state of Massachusetts, but also this has been seen nationally. And, you know, clearly COVID-19 is one of many clinical conditions that we've shown through our literature recently that we have disparities in care. And so this is the IHI framework for how we address health inequities. And you can see many of the similar themes as you heard back in the Caring for the Caregiver report, but really what they advocate for is making health equity and improving health equity a strategic priority, working on structures and processes that support this improvement work, and to address social determinants of health, particularly those that as healthcare organizations we might be able to impact, and also really tackle structural racism at an organizational level, and then also the partnership with communities. And so, as you can see, a pretty comprehensive plan, and I've included the link again here to those who might be interested in that report. But I think that what we've seen with COVID-19 and looking at this issue of health inequities is that we can improve them. So this is an example from Minnesota that looked at the differences in outcomes of cancer screening rates for colorectal cancer and breast cancer, and looked at them by race and also by health insurance status, and showed that obviously there was a gap. Based on this data, they did improvement work and were able to close the gap of these deficits in all areas and in both demographic groups. I want to highlight great work that was done by many others in the organization at UMass Memorial Health around closing health disparities in well child visits. And so as a healthcare system, we've taken a similar approach to how we deal with this. And so in this graph, you'll see here on the left-hand side where we started in terms of health disparities and well child visit completion and by race, and where that ended up. And so both an improvement, but also closing of the gap, which was terrific work and recently nationally recognized. So, I think clearly this will take a comprehensive strategy. It's not just policy, it's not just institutional work, it's not just community work, it's really all of us. We need to really, I think, understand better structural racism and how that affects us in healthcare. And I think we need to make this more of a professional value and really incorporate it into how we do things. And that goes to how we train our physicians as well. Really, the way I look at this is health disparities work, you can argue, is really population health, and there's no difference in those two related concepts. So I think, improving health equity will take a comprehensive strategy, as I mentioned, and I think we need to figure out how we're going to move forward in this paradigm, thinking about this as a key professional value. So to take a step back, I think talking about burnout and health equity and how they relate to quality and safety and the pandemic's impact has crystallized some key relationships. Historically, quality and safety has been a concept that we've looked at, but initially when we started with patient experience work, we started to say, oh, quality and safety is synonymous with patient experience. Like, in other words, you can't work on one without addressing the other. And I think now, thanks to our understanding and some of the pressures driven by the pandemic, I think health equity and burnout, you could call that wellness or engagement as well. Both, I think all of those are related concepts. These are actually all now interrelated concepts that I think are tracking with quality and safety. In other words, when we say quality and safety, I don't think we can exclude talking about patient experience. I don't think we can exclude talking about health equity, and I don't think we can exclude talking about burnout. And said another way, you can't really improve quality and safety if you don't also address these key factors. And so that, to me, is really the new paradigm in which we need to move forward as a field and try to really look at this comprehensively. And what that also means is, as you saw in the MHA report and in the IHI report for caring for the caregiver and health equity, they both advocate for comprehensive, systematic approaches to addressing it. And again, I don't think that as healthcare institutions, we can really look at this and say, oh, we're going to have three comprehensive multilateral strategies on three different topics. We need to look at this as working on quality and safety, so that it's, when we set strategy and when we think about how we're going to improve as a field, we need to look at that as addressing all the same thing. And then I think it won't seem as overwhelming if we look at it as all of a combined benefit. So let me shift gears a little bit and talk about another topic that I think will be of impact to our practice, your practice, and that's the role of big data, artificial intelligence, and sort of the intersection of that. So when I say artificial intelligence and healthcare, I feel like there's two potential different models that people might conjure up. So top left with Luke and Leah there is the robot doctor delivering care versus the bottom right picture, which is not quite the same. So there's a doctor and a patient there supported by other means, the robots there. And so there's a subtle difference here, but I think it's an important one. And I think in my mind, when I think about artificial intelligence and quality and safety, whether you want to talk about informatics or big data or whatever, I think the model we should be driving towards, particularly in the at least near medium term, is the right-hand corner. I think it's really how do we harness the power to support the clinicians, not how do we jump to replace the clinician, which is a very different end goal. And I think the bottom right holds a lot more promise for us in improving our healthcare rather than aiming for the top left. That being said, all of this is within a gradation. So when we talk about how artificial intelligence might support us as clinicians, there's clearly a gradation of what the tools can do to support us. And eventually, you know, if you keep going on towards the northeast corner of this graph, it clearly becomes more of that Luke and Leah supported doctor robot model. But I think that's clearly way far out in the future and not something necessarily we should be shooting for in the short term. A couple of examples here from around medicine. So this is a study that looked at AI-assisted mammography and looking at cancer detection rates in, with radiologists looking at mammograms, showing that AI support can boost the diagnostic capability of the radiologist. Very similarly, there was a study looking at AI-assisted colonoscopy. So as you're doing the colonoscopy, it sort of helps you identify polyps, and in both detection of polyps and adenoma, clinicians seem to do better when assisted with AI. So certainly seems really promising. And in outside of radiology and gastroenterology, a key factor is around diagnosis, so delayed diagnosis, misdiagnosis. So another way that some of these tools have been developed is to try to tackle the issue of diagnostic error. And so a study looked at how good some of these products are. When you look at this table, they scored how they did on some of these cases, as you can see here, whether they be mix-up cases or New England Journal of Medicine cases. And the two that seemed to rise to the top were Isabel and DXplain. DXplain was developed just down the pike at Mass General as an offshoot of some of the work that they were doing there in the lab of computer science. And when you ask the question, though, do they work? I think that this is really still very much in its infancy. So, you know, really with DXplain, really can't find a study on clinical impact. There was definitely a study that showed a reduction in cost of care. Isabel, which is another product, there was a study that looked at the implementation of Isabel in diagnosis and whether diagnostic errors of omission were reduced using Isabel. Seemed to show some signal that it does. And it, you know, they did aid in diagnosis generation, but generally when these studies are done, they're looking at, did the computer system name one of the diagnoses that it ultimately was, and they're doing this post hoc. They're not doing it in the situation of a real life use, clinician using it in the care of a patient. So I think we are clearly way far off from some of these technologies. And really the issue I think is with these tools is that we need to make sure that the training set, for example, that you're creating some of these tools with is big enough to cover the breadth of clinical experience that a clinician might bring to bear on a clinical case. Generally, they don't have electronic medical record integration, which makes it very cumbersome to use in the workflow of a clinician. There's inherent bias in that information that we have to really be careful of. And also, it oftentimes requires manual input, which makes it frankly almost unusable. And if you think about that model of the doctor with the child, with the robots floating around it, I mean, clearly the vision isn't that the doctor, steps out and talks to the robot and then comes back to the patient, right? And so I think clearly we need better integration with the workflow for these systems to really be of any value and to sort of take hold. In thinking about this question, I really thought about like, well, what have I done? And, I think a lot of us might admit we've done the Dr. Google search. And actually, Dr. Google does pretty well. There was a study that looked at 26 New England Journal of Medicine clinical pathological conferences cases, and they got the right diagnosis 58% of the time just by plugging it into Google. And frankly, that was about the same accuracy rate as some of those other products showed in that study that I showed you before. So Dr. Google's not so bad. When we think about things like this, machine learning, artificial intelligence, here are some of the things that we really need to be careful about. There's this concept of distributional shift. So where you train call it the algorithm on one set, and then you put it into a new environment where it wasn't trained, and then it leads to a wrong prediction. An example of this outside of medicine is, for instance, a set of military-based tank simulations that is aimed to fire at a target was all trained on the daytime. You all of a sudden put it into a nighttime scenario, and then it can't really identify any targets. We need to clearly calibrate outcome and impact within these models, and that can be a pretty tricky thing. It can be really hard to detect what biases were inherently built into the model by the folks who built them, and so that it can be propagated through as you're using these systems. And we need to make sure we have an understanding of confidence. So, in a clinician, you might say, well, I think this is a low probability diagnosis, but, X, Y, Z. But really a computer is going to say, this is what I think it is. And it may be very opaque as to what the confidence interval around that prediction is. And as machines get better, clinicians may conversely actually develop biases that the machine isn't correct. So if they get 9 out of 10 correct, or even say 10 out of 10 correct, they might assume that the 11th is going to be correct, and this becomes an enabling kind of thing. And really, some of these future-based algorithms can create can do exploration. So this is where they're kind of doing pressure testing and case testing on their own. And how do you put boundaries around that is still an open question. And another good example that's been discussed is, for instance, an algorithm designed to get patients therapeutic on heparin drips faster might actually start to think that the objective is just to make sure that the PTT is within range whenever it's checked. And so maybe it just boluses the patient right before the lab check is due and then hits the goal. But actually that doesn't achieve therapeutic anticoagulation, which is what we're trying to get to with heparin. So it may be that it drives towards solutions that are just trying to merely win a game that it thinks it's playing, or just frankly is unrealistic. Like maybe it says, hey, instead of checking a PTT every 6 hours, why don't we check it every 1 minute? And clearly we're not going to be able to do that. So here's my prediction slide on this one, and how will artificial intelligence support our quality and safety? I think it's here to stay on this one too, similar to virtual care. I think we've only really skimmed the surface of the potential of this. I do think that artificial intelligence and digital medicine can make us better physicians. I don't think that we should be replacing docs. I think we need to be supporting docs. And, you know, the digitization of medicine, I think we need to proceed with full caution, and that realizing that there are very serious upsides and downsides. And it's really not similar to the introduction of the iPod, for example. It's not like we're just going to turn on some of these systems and all of a sudden medicine is going to transform. There are a myriad of complications that I mentioned that we have to be considerate of as we move forward in this journey. And I think this is another area where we have to keep a very close eye on our quality and safety and its impact to the care we deliver. Just in summary, I hope that I've shown all of you that the COVID-19 pandemic has had a huge impact on accelerating some of the key aspects of quality and safety, and that otherwise may have taken a longer time for us to really work on, prioritize, however you want to say it. We can't improve quality and safety without working on patient experience, clinician well-being, and health equity. As I showed you in the diagram, I really think that those are coexisting and concepts that travel in parallel. Digitization and automation of medicine will accelerate moving forward. And I think the key question there is, are we really ready to harness its power, and do we understand all of the things that it's going to do? But I think one thing is true, which is that, you know, we should apply our lessons learned in the past to drive our success in the future, meaning, you know, we as a field adopted the concept of quality and safety as a central tenet. I don't think anybody here would argue that quality and safety is not a thing in medicine. And so very similar to that, I think we're going to embrace all of these concepts as a field. And so we just have to make sure that we take it systematically. We keep our patients at the forefront and increasingly make sure that we're taking care of each other as we're doing this. So here are my references for those that are interested. And I just want to say in closing, I'm again deeply humbled and honored to be asked to participate in this forum and to just share some of these thoughts with you tonight. This has been a tremendous opportunity, and really want to thank the Worcester District Medical Society, Spiro, Martha, for inviting me to this venue tonight. And again, I look forward to our in-person meetings and getting to connect in person with each and every one of you. But in the meantime, I'll transition now to questions and see if there's things I can answer. So please go ahead and enter your questions in the Q&A box here. So let me take a couple of these in turn as we get a couple more of these questions here. So a question is, in pediatrics, we're concerned that by not seeing children in person and with children not in school, we may be missing child abuse cases that often increase during difficult times. Any comments or insights? Yeah, I think this is right on. And this is very similar to my concerns around, you know, the fact that we're not putting hands on patients and some of the subtleties and cues that we depend on as clinicians during an encounter, such as a question that a patient just kind of, you know, just acts the wrong way, or there's weird body language that we don't pick up on. Things like that are going to get lost. I think it's really also hard, particularly in the realm of pediatrics, to get a sense of context. So, you know, clearly, I'm not a pediatrician, but clearly context with the parents and the child is an important dynamic that you're also assessing as a clinician. And I wonder whether in virtual care that gets lost. And so I think these are some of the things that we're going to need to very clearly and explicitly track and answer, because clearly we don't want to adopt and progress in virtual care only at the detriment of things like that. Here's another question. So with physicians and healthcare workers retiring early, how will quality care be delivered to current caregivers in the future? Yeah, so I think this is something we're going to have to grapple with. My hope is, I'm going to answer this question in a couple of different ways. My hope is that our education systems start to incorporate some of these concepts that I discussed about the interconnectedness of some of these concepts of how well-being and burnout and all those things affect quality of care. And so therefore it's important to account for those and see that as a quality and safety issue. And so I hope that in our educational systems, we are starting and we'll start to and continue to promote building in teaching our medical students and residents and other trainees about the importance of this as a profession. So that's one thing. I think the other thing is we need to make sure that we watch out for the impact of this gap that's kind of alluded to here, where we might lose our senior-most folks early and be kind of left with a bit of a vacuum. I think that's clearly a concern. You know, it's not, we thrive because of mentorship, right? Medicine has always been an apprenticeship model. And so it's not a good thing necessarily when we lose our senior-most clinicians. You know, I think that is a clear concern that we're going to have to grapple with. And like I said earlier, if we are able to deal with this effectively, quickly, I think that's what's going to bring us success. Next question is, we often see NHSN data and say we should take off our clinical hat, and when we see these data, will this translate across all quality metrics? If yes, it will be less than perfect. Yeah, I agree with this comment, you know, and I think that there's one of the things that I didn't talk about was really around this topic of metrics and measurement and quality. And I think that that's clearly a key area of quality and safety. I just didn't talk about it too much tonight, just given that I thought a more, you know, it would be less applicable to most of you. But I agree that, you know, we do need to think about the impact of these metrics on how they incentivize certain behaviors within our practice, given their disproportionate effect on how people act, and, you know, particularly if you implement them at a policy level. Just thank you all for coming tonight, attending tonight. This was a lot of fun, and hope that I see many of you around the medical center in Worcester, and please don't hesitate to reach out if there's anything that I can do. I'm happy to elaborate more and talk more about any of these topics. So thank you very much.